Good morning. This meeting of the Baltimore City Council Health, Environment, and Technology Committee is now called to order. I am Danielle McCray, Councilwoman representing the 2nd District and Chair of the committee. In attendance today, we have Councilman Mark Conway from the 4th District.
Thank you, Madam Chair.
We have Councilwoman Felicia Porter from the 10th District.
Thank you, Madam Chair.
And we have Councilman James Torrance from the 7th District.
Thank you, Madam Chair.
Thank you. Councilman Dorsey will be arriving shortly. And also in attendance, we have Matthew Peters, staff to the committee, as well as from the mayor's office, Sophia Gebran-Hewitt is in attendance today. So before we get started, if everybody can just take a moment just to turn off or silence your cell phones. Also, if you have joined us in the council chamber, actually, let me skip that part. Today, the committee is going to be holding hearings on Resolution 21-0039R, Violence Against Women and Overlooked Public Health Crisis, and Resolution 21-0071R, Investigative Hearing Developing a Coordinated Response to Baltimore City's Overdose Crisis. We are going to start with Resolution 21-0039R for the purpose of inviting relevant agencies and certain community-based organizations to appear before the Baltimore City Council to discuss the rise in violence against women and what strategies are being put in place to reverse this epidemic. For this hearing, we're going to start with updates from the agencies, and then we're going to have an opportunity for committee members to ask questions. I do want to begin by thanking everyone for being in attendance this morning. This is our 4th hearing investigating current statistics, getting a greater sense of each agency's initiatives and resources, and analyzing cross-agency collaboration, and discussing shortcomings, successes, and timelines. We know that crime in our city does remain at the forefront of all of our minds. This epidemic has not left us, and through precedent, we know that sustainable change comes from effective cross-collaboration. I am looking forward to this hearing as we start this new year with the same vision, and that is ending violence against women. So we are going to start with our agency reports. We're going to start with the Baltimore Police Department, and I'm going to thank them in advance for sending over a decent amount of data. Colleagues, you should have received all of the information from agencies yesterday.
Thank you, Madam Chair. I'm Shannon Conway, Legislative Coordinator for BPD. I'm joined by Colonel Monique Brown and Colonel Kevin Jones, and we stand by our original report, and Major Latanya Bishop of Special Investigations. We stand by our original report and stand ready to provide updates and answer any questions that the committee may have.
Thank you, and we're going to, and committee members, I do just ask that you hold your questions until we have heard from all of our agencies. We're going to go to our health department, who does have a presentation that they would like to share.
Yes, thank you. Good morning. My name is Julia Roche. I am Legislative Affairs Director at the Baltimore City Health Department. Dr. Zarasa, unfortunately, was unable to attend today as she was scheduled for jury duty. I know you are aware of this, but she has sent designees. I am accompanied by Rebecca Deneen, Assistant Commissioner of Maternal and Child Health, and Aisha Burgess, Director of the Office of Youth and Trauma Services. We do stand by our original report, and we request a verbal presentation to provide you with some updated information. Thank you.
Thank you, Madam Chair, and glad to be here. I'm Rebecca Deneen. I'm here to talk to you about the Bureau of Maternal and Child Health and the programs and services we have within this bureau. Thank you, Director. I'm here to talk to you about the Bureau of Maternal and Child Health, starting with our maternal mortality review. I'll then talk through what we do for screening for violence. And then I will share I'll pass the baton over to Director Aisha Burgess. So for maternal mortality review, first, We review violence-related initiatives within our Bureau of Maternal and Child Health through something called Fetal and Infant Mortality Review. We have Child Fatality Review. And then we recently introduced Maternal Mortality Review in June of 2021. In the Maternal Mortality Review, we identify maternal deaths. We review the medical records and other relevant data related to those deaths. We then determine how we could prevent the deaths, and we develop recommendations for prevention of these deaths. From there, we either take action on it or we disseminate to the correct agency and policymakers for change to take place. It's one of the few local maternal mortality reviews in the country, and we passed the legislation, as I said, with support from the city in 2021. Homicide is the third leading cause of maternal mortality in Baltimore City. We only have data through 2017 because of the delay in how you establish the cause of death. But between 2013 and 2017, there were 75 maternal deaths in the state of Maryland, 9 of which were in Baltimore City. Many of these deaths are considered pregnancy-related because the perpetrator's reaction to the pregnancy itself is that it precipitates the violence. The Baltimore City's team, the recommendations that we have had related to prevention of maternal mortality is to conduct education on intimate partner violence and consent in schools, including with students who receive special education services. Our other major recommendation has been to reestablish the Domestic Violence Enhanced Visitation Program, which is called DOVE, which is an evidence-based intimate partner violence intervention program in our home visiting services in the city. And we previously had this program going as a pilot site and did not receive funding for it. In terms of screening, and again, our work in maternal and child health is primarily upstream, so that means that we're looking for ways to prevent violence from happening. But what we do downstream is screenings for violence. So through our Be More for Healthy initiatives, which was originally a strategy to prevent infant mortality and has been including maternal mortality since for a couple of years now. Our critical points of screening prevention is through our first prenatal care visit, which is documented through a prenatal risk assessment. This risk assessment is sent to Healthcare Access Maryland to trigger care coordination of women. Through care coordination, within 10 days of receipt of this prenatal risk assessment, we talk to the women. We might link them to home visiting services and WIC services and other services. We ask them and screen them for domestic violence. And then if it screens positive, we refer to House of Ruth, turnaround, housing supports, and other community resources. Through the Pregnant Persons Home Visiting Program, at multiple intervals, they are screened from pregnancy to 2 years old for domestic violence. And at delivery by the birthing hospital, we also trigger a review process through a postpartum and infant maternal referral, which also allows us to have a referral to HCAM and screen women for domestic violence. We also have under this initiative a sexual health initiative called You Choose, and we also have Title X money that goes into family planning clinics. Under You Choose and our Title X family planning, we screen all patients, young people, 12 and older, for interpersonal violence, and then we have one social worker at our clinics who links these young people to resources, again, including House of Ruth, Turnaround, and other community services. So finally, I'm going to I'll share some data for you about our programs. Annually, we screen about 4,000 pregnant and postpartum people through these risk assessments. We screen about 1,000 pregnant and postpartum people through home visiting. We screen about 3,000 pregnant and postpartum people through our WIC program, which also screens for domestic violence. We screen about 1,200 adolescents and young adults through our Title X clinics. Again, our screenings are conducted by trained nurses, social workers, and certification specialists, and sometimes community health workers. And when these results are positive, we engage in a conversation about safety and resources. And since the onset of COVID-19, many of our programs have been using telehealth, which has presented some challenges. What we know from the research is women are unlikely to disclose before 5 to 7 asks. So it takes quite a while to build the trust that's needed. So these screenings, while we do it very broad, because we don't have a directly funded domestic violence program, we realize that this is just getting at the surface of it. In terms of our sexual health prevention and education, we work with city schools as part of You Choose. We provide comprehensive reproductive health education to middle and high school students. And this is inclusive of education and outreach on the importance of consent prior to sexual activity to youth of all genders. And this is in the classroom that we do this online and through social media. And the goal is to reach all middle and high school students with this program. Again, when we see that there's an issue of domestic violence, the school health clinicians, the school health aides, the school health nurses refer to the partners I've mentioned before. I was asked to talk a little bit about funding. Our domestic violence is integrated into our work streams, so we do not have a specific funding line item for this. These work streams are covered by general funds, by state grants, and by federal grant funds. And I will pass this over now to Director Burgess.
Good morning, Madam Chair. Again, my name is Aisha Burgess. I am the Director of the Office of Youth and Trauma Services. And the Office of Youth and Trauma Services have been implementing violence prevention programs since its establishment in 2002, when it was formerly known as the Office of Youth Violence Prevention. In 2011, the office began to look at teen dating violence as a type of violence that we wanted to focus on, and we received funding through the Center for Disease Control and Prevention to implement the Dating Matters Initiative, which was strategies to promote healthy teen relationships. And through that initiative, which was a 5-year demonstration project, we learned that there was very little evidence in the field around teen dating violence. And there were some policy gaps as well as it relates to that initiative. And so what we have done is we implemented and evaluated the Dating Matters program in 13 Baltimore City middle schools. And we found that as a result of that project that there has been some promising effects from that. In addition to implementing prevention strategies, we have also begun to look at intervention as it relates to violence against women. And so in 2016, we received funding from the Governor's Office, then the Governor's Office of Crime Control and Prevention, to implement the Youth Services and Advocacy Project. The Youth Services and Advocacy Project serves youth between the ages of 11 to 24 and their families who are primary and secondary victims of violence. We have worked through government and community-based partnerships to provide case management support, referrals for mental health services, and other supports. And we also engaged in non-traditional therapeutic interventions. The program since year one has grown from serving 30 victims annually to 150 victims and survivors annually to date, with at least 75% receiving intensive services and supports. Between 2020 and 2022, the program served 304 individuals who were affected by intimate partner violence, in which 80% were women victims of domestic violence, and 65% of those served were provided with relocation services and housing subsidies, as well as connections to mental health services, and that was 70%. The Youth Services and Advocacy Project was trained by the Governor's Office on the Safe at Home program, which is the address confidentiality program that closely works with government agencies to keep survivors' location and address off public record. The supports that the program provided, in addition to the mental health connections, were assistance with job placement, job readiness, transportation assistance, educational services, individual training accounts around daycare and phlebotomy, relocation funds, trauma-focused peer groups, as well as referrals for legal services through the RISE Center and Rebuild, Overcome, and RISE Center at the University, RISE Center, which is the Rebuild, Overcome, and Center at the University of Maryland. Our partners through this process have included the State's Attorney's Office Victim Services Unit. We have made referrals to the House of Ruth, as well as received referrals from the House of Ruth for rental subsidies. We've worked with Baltimore City Schools, as well as MONSE, We Are Us, Baltimore Police Department, ROCA, ROAR, and Park Heights Renaissance, as well as the Center for Hope. The project also, in addition to receiving agency referrals and community-based referrals, we also accept self-referrals. Currently, the program is receiving current level funding at about $487,000. And the program, again, has been funded through 2016, and it funds a staff of 4, which includes a supervisor and 3 youth advocates. Funds are used to allocate resources to victims, such as employment training and medical service certification training accounts, gift cards to address food insecurity, and assistance with funeral expenses. As I said, we have been implementing both intervention and prevention programs. And so our Supporting Our Students project, which was funded by the CDC in 2016 to 2021, was designed to implement strategies to prevent teen dating violence and youth violence by addressing the shared risk and protective factors. Through this program, we implemented a comprehensive evidence-based prevention model to stop teen dating violence to middle to high school students in grades 9 through 12. Through this program, we reduce behaviors that increase the risk for dating violence, like substance abuse and sexual risk-taking. And we prepared youth to identify abusive relationships and to recognize signs of teen dating violence, connected both victims and perpetrators to appropriate resources, and we also were able to increase help-seeking skills. This initiative is a perfect example of looking at this problem and going upstream by focusing on the root causes, and as I said, the associated risk factors and protective factors for teen dating violence. So while active, the Supporting Our Students team trained between 6 to 22 prevention program implementers, some of which were community-based implementers and school-based implementers. In years 1 through 4, the program was implemented in 4 Baltimore City high schools. And then year 5, we added another school and 3 community-based sites. We educated about 835 Baltimore City youth on identifying behaviors that could lead to dating violence and how to connect to resources and conflict mediation skills. The prevention program sessions implemented the Safe Dates evidence-based curriculum, and conflict mediation was administered to about 1,070 youth over the 5-year period. Funding for the program concluded in September 2021 with an extension to April 2022. And BCHD has submitted an enhancement request to continue this work for fiscal year 2024. We are asking we're in our request to restore and expand the expansion of the Supporting Our Students program to help also bolster the YSAT program as well. We are looking to increase citywide cross-sectoral involvement in teen dating violence and youth violence strategic planning and implementation, and the implications for further development of school-based foundation for youth violence and intimate partner violence as key issues in the Baltimore City Comprehensive Violence Prevention Plan. We feel that by implementing prevention efforts and a racial equity policy initiative, the Supporting Our Student initiative will continue to facilitate evidence-based and evidence-informed programming and strategic collaboration related to other citywide trauma responsive and community violence intervention initiatives. Before I go, I'd just like to share a little bit of data from the CDC's National Intimate Partner and Sexual Violence Survey. About 1 in 4 women have experienced contact sexual violence and physical violence or stalking by an intimate partner during the lifetime and reported at least one impact of that violence, likely being concerned for their safety. Over 43 million women and 38 million experience psychological aggression by an intimate partner in their lifetime. And when we have learned that when intimate partner violence occurs in adolescence, we are looking at teen dating violence. And we have found through this study that about 11 million women and 5 million men who reported experiencing sexual violence, physical violence, and stalking by an intimate partner in their lifetime said that they first experienced these forms of violence before the age of 18. According to the 2017 Youth Risk Behavior Survey, Baltimore high school students reported experiencing physical dating violence at 8.3% compared to 11.6% in the state of Maryland and the national average of 8.2%. We feel that these strategies to promote healthy teen relationships is an important part of prevention. Thank you.
Thank you. We're going to move on to Monty at this time. Excuse me, the Mayor's Office of Neighborhood Safety and Engagement.
Good morning. Thank you, Chair McCray and members of the committee for convening this hearing and for inviting Monty to speak on the issue of violence against women. I'm Director Shantae Jackson, and I've served as the Executive Director of the office since January of 2021. I am joined by members of Monty's Victim Services team and our Policy and Research team, which houses our data analytics team members. I'm grateful for the opportunity to speak to you all about the problem of violence against women in Baltimore City, and in particular against Black women and girls in Baltimore City, and to share with you the role that Monty plays in working collaboratively with the other agencies that are here with us today and community-based organizations to reduce violence and to provide supports and services to direct victims as well as others impacted by violence. While I will not be going through the slide presentation, we did want to make sure that we brought it up so that if there are questions specific to intimate partner violence stat, which we rolled out a few months ago, that we are able to reference those slides for you. Monty's work in this area in particular includes efforts to reduce sexual assault, human trafficking, and gun violence. We've created an enhanced focus on intimate partner violence, and Wendy Lee, who is the Deputy Director of our intimate partner violence work, will be speaking to you all in a moment. To that end, the Victim Services team has filled all of the vacancies that it has had and has onboarded new hires dedicated to intimate partner violence prevention as of October 31st of last year. Monty's also created an innovative public safety accountability dashboard, which shows domestic violence incidents by neighborhood, as well as arrest and disposition data. This dashboard will be released to our community, to the public, by mid-February. The continued rise in violence against women makes it more imperative than ever that we rely on data to inform our approaches and that they are evidence-based so that we're effectively addressing an often overlooked problem. So in speaking about some of the numbers, the problem against violence of women in Baltimore City are highlighted by some of the statistics that I'll share with you now. In 2022, women made up more than half of all victims of aggravated assault, 53%, and 97% of rape victims. In 2022, we saw 111 women victims of homicide or non-fatal shootings, and the figure was even higher in 2021 with 141 women who were victims of homicide and non-fatal shootings. A significant number of women were robbed or carjacked in Baltimore. 4 in 10 robbery victims and roughly 1/3 or 34% of all carjacking victims were women in 2022. With regard to interagency collaboration and the work that MONSE is doing there, you've heard our partners at the Baltimore Police Department and the Baltimore City Health Department reference the work that we're doing together. The Public Safety Partnership requires interagency coordination and convening via the Victim Services Working Group, along with the Criminal Justice Coordinating Council work that the agency performs. Baltimore City Visitation Center is also an example of the collaborative efforts that we have between our office, the district and circuit courts, the Baltimore Police Department, and the House of Ruth. Ballet After Dark is a community-based organization that MONSE has funded and is just one of those that MONSE has intentionally partnered with, who focus on supporting women victims. And this organization in particular was founded by a survivor of sexual assault. I'm gonna pause here, Madam Chair, and turn it over to Wendy Lee, who will be sharing some specific information associated with the work that MONSE's doing on intimate partner violence. And then we'll turn it over to Tom Stack, who is the manager of our anti-human trafficking efforts and our sexual assault response team. Wendy?
Good morning, Madam Chair and our Honorable City Council. As Director Jackson said, my name is Wendy Lee. I'm the Deputy Director of Intimate Partner Violence Prevention for MONSE. And I'd just like to start off first thanking all of us that are here today who are trying to address this issue of violence against women. Everything that you heard today is a collaborative effort, and it'll take all of us to make sure that we're moving the needle. But I want to start off before I jump into intimate partner violence statistics and just talk a little bit about domestic violence crimes as a whole and give the committee and everyone in the chamber an update. As a whole, domestic violence crime, as it relates to total crime, we're seeing a reduction. There's about a 3% reduction in domestic violence crime as it relates to the percentage of total crime. We're also seeing that property crimes are up. So domestic violence property crimes are up by 9%, driven mostly by domestic violence larceny. And so we do need to dive a little bit deeper to see what is happening there. As far as domestic violence violent crimes, we are down by 8% overall. And domestic violence homicides, particularly IPV homicides, are down by 18%. So we are seeing some movement in the right direction through all of the collaborative efforts that we're hearing about today. I want to dive into a little bit deeper into intimate partner violence and provide a little common language too, because my title is Intimate Partner Violence Prevention, but we often use the term domestic violence. And so when I speak to you today, I really am talking about the relationship between parties who have an intimate relationship, a romantic relationship, before or now. It does not discredit the amount of attention that needs to be placed to issues of child abuse and child neglect and elder abuse. Those are very important issues as well. The team in MONSE is starting with a focus on intimate partner violence, but do intend to expand our scope at some point in time. I do want to talk about this team. It is brand new. In terms of, as Director Jackson said, we just finished filling some open requisitions in October of 2022. So we're a little over 4 months old, but in that short span of time, we've been doing the work. In this foundational year, the objectives of MONSE's intimate partner violence prevention efforts are really to promote collaboration and an integrated, holistic approach to how we end intimate partner violence. That does mean that we need to take a look at more than just the direct victim, but also indirect victims, such as children, and those who have caused harm. Abuse intervention is also part of the equation. We have to remove the sole responsibility of a victim's safety from the shoulders of victims and from the shoulders of law enforcement and all of the agencies that are around and supporting victims. We have to give them the services and access to resources so that they can promote safety planning of their own as well. So in the coordination space, MONSE's Intimate Partner Violence team is also heavily involved in 3 coordinated committees that convene just shortly at the end of the year. We have our Domestic Violence Fatality Review Team, which I'm happy to say launched in August of 2022, and we're doing case reviews at this time. In fact, we're doing a case review that crosses over Baltimore City for a case that many of you may be familiar with. And we'll be doing the review with Howard County to make sure that we understand where that cross-collaboration may be impacted by jurisdictional boundaries. And interestingly enough, there are issues there that are beyond just the traditional criminal justice system and reach into the civil justice system as well. And so we want to address and understand those issues. We also have the Domestic Violence High Risk Task Force, which is a grant-funded program, a grant-funded task force through the Office of Violence Against Women. That group has a specific focus to understand the risk assessments that are currently being used across our systems, how we share that data, where we can do more assessments to understand where there are victims that need services. Coming out of that, we hope to have a strategic plan within the next few months that will have to be approved by our funder. But our main goal is to understand, once you assess someone, how do you continue to stay in contact with that person? If there's an elevated level of risk, how do we work together? It's beyond the assessment, it's more about the response and the continued efforts that we lift up for those victims of domestic violence. Our Domestic Violence Coordinating Council, that is our higher level of our 3-prong approach. That committee is looking at more broad-based system strategies as well as coordination amongst our principal agencies. Also having the weight of the Mayor's Office and the Criminal Justice Coordinating Council to move items that we feel are a priority forward collectively. All right, in terms of some of the MONSE programs or MONSE efforts that we are involved in, I want to talk a little bit about our ARPA funding. We do have some initiatives that are focused on abuse intervention programming, working directly with agencies such as My Covenant Place, their Alpha Project, the House of Ruth's Gateway Project, and Turnaround's abuse intervention programming. Each of those have a very specific target, with Turnaround being teens, with the House of Ruth being overall abuse intervention programming, but also making sure that they remove some of the barriers that prevent individuals from completing their programming, such as fees and drop-in services and wraparound services, so that they can get the support that they need. As far as community engagement, we've all talked about the importance of being in the schools, and I'm glad to hear that we're doing that. MONSE wants to partner with, and will be partnering with, the One Love Foundation, which is heavily involved in reaching teens and middle school middle school students in the school system. But we want to partner with them to reach the community, fraternities, sororities, faith-based universities, community as a whole that can be able to see themselves in this co-production of public safety. We're also going to be using them to help us reach LGBTQ, faith-based communities, and as I mentioned, fraternities and sororities. Homicide reduction. It is very important that we reduce these numbers of domestic violence homicide, and we are seeing a reduction. But we do need the data, so we're working on making sure that we have the data to understand the trends. And we're also making sure that we're doing more assessments and responding in a way where people can prevent or be aware of the risks associated with lethal situations. Finally, as I said, and as it was mentioned by Director Jackson, we have launched IPV STAT, the first version of it, which is really meant to take a look at a number of different measures across the process of safety for victims and accountability for offenders, and see where there might be some issues that we need to close or address. That data is being looked at or will be evaluated by the Domestic Violence Coordinating Council, and we're happy to share portions of it with the council and give you access to see all of the measures on IPV STAT. Thank you. I'll turn it over to Tom Stack.
Good morning, Madam Chair and council members. My name is Thomas Stack, and I'm the Anti-Human Trafficking and Sexual Assault Response Manager for the Mayor's Office of Neighborhood Safety and Engagement. Whew. That's a title. MONSE is a partner of with the Baltimore County Sexual Assault Response Team, also known as SART, which aims to provide a collaborative, victim-centered, and trauma-informed approach to respond to sexual violence in our community. MONSE and other sexual assault professionals have also began planning an outreach and education program working with students at universities and Title IX coordinators at universities to provide awareness on college campuses. Phase 2 of that program is going to be bringing sexual assault awareness to Baltimore City high schools and also to the public. The anti-trafficking efforts, Monsi, myself, I'm the co-chair of the Baltimore City Human Trafficking Collaborative, which is a diverse group of about 40 to 50 stakeholders working together in the city of Baltimore to end sex trafficking and labor trafficking through by raising awareness, assisting with investigations and prosecutions, and most importantly, supporting victims of trafficking through a victim-centered, trauma-informed approach. MONSE and the Mercy Medical Center has begun a initiative called, which began in 2019, began an initiative called the Blue Dot Program, which is it's actually become a national gold standard program, a one-of-a-kind program in the United States that is emergency services for victims of trafficking. This ensures that no victims of trafficking in the city of Baltimore fall through the cracks, that everybody is brought into this program, receives the appropriate services. It's a 24/7 program, and since March of 2019, when we started it, Mercy has served over 300 survivors of trafficking. MONSE is also proud of the Human Trafficking Grant Program, which is designed to work with nonprofit organizations in the city of Baltimore. And since its inception 3 years ago, MONSE has awarded over $900,000 to organizations working in the city, all throughout the city, to end human trafficking. And I'll turn it back over to Director Jackson.
Thank you, folks. Madam Chair, in addition to the comments that have been shared today, again, would reference that we do have a PowerPoint presentation that fully demonstrates the implementation of what we call IPV-STAT, and are willing to answer any questions that you or members of the committee have for us. Thank you.
Thank you all. We're going to go to Mayor's Office of Children and Family Success.
Good morning, Madam Chair, council members. I am Dr. Deborah Brooks, Executive Director of the Mayor's Office of Children and Family Success, and we stand by our report that we submitted.
Thank you, Dr. Brooks. Is there anyone here from the Sheriff's Office or the State's Attorney's Office? Okay. City Solicitor's Office, do you also stand by your report? Yes, we do, Madam Chair. Okay, thank you, Elena. And Elena, can you just scream out your name for the record, if you don't mind? Thank you. So we're going to go right into questions from the committee. And actually, before we do, I just want to make sure that I acknowledge Councilman Ron Dorsey from the 3rd District who joined, as well as Councilman John Bullock from the 9th District who joined. And my first question, this can be for you, Director, or it can be for Deputy Director Lee. We spoke about your team, and you did say that all positions were filled October 31st of 2022. I had some follow-up questions from the last hearing, and bear with me just a few moments. I want to speak about the IPV prevention coordinator and the court liaison. So the first question is just understanding the roles and day-to-day responsibilities of those two positions.
Yes, ma'am. We'll have Deputy Director Lee come up in a moment. What we're sharing with you all in the presentation now is the org chart associated with the intimate partner violence lane, so that you see the context in which the coordinator and the court liaison sit. And this may also inform any additional questions you might have. Director Lee, when you're ready.
Thank you. So the Intimate Partner Violence Prevention Coordinator is a brand new position, and that person they will have a number of responsibilities, Madam Chair, but primarily it will be about helping us do a better job at coordination. So when we talk about the Domestic Violence Coordinating Council, they're a member of that, the Fatality Review Team, so they're on all of those. But they're also there to do some training. So the specific person that I hired to this position has a background at the State's Attorney's Office as a victim's advocate, focuses on the LGBTQ+ community, very much astute in that community, has a faith-based background. So in terms of us reaching the community, this particular person will play a heavy role in doing that. Additionally, this person will help us develop the strategy in terms of different organizations that we need to partner with, and how do we really work together. Coordination is a big piece of this. And help us understand where we stand in the gap to fill things that other agencies are doing, but how do we be a partner to those agencies? So that person will be the first point of contact. As far as the court liaison, we do recognize that, and there's some data in the slide deck, that when folks do get a protective order, which that was one of their primary ways of promoting their safety, we do see a situation where many may get the initial protective order but not come back for the final. And there's about 50% don't actually get a final order. And a lot of us will think it's because maybe they didn't meet the standard of proof. That's not it. They actually failed to show. And so that may mean that maybe they're not connected to services. Maybe they're intimidated by the court process. So that court liaison is going to be present in the court to help victims who are coming there for protective orders and trying to seek safety, to help them understand the process, do an assessment, understand the risk factors that are involved, particularly lethality risk factors, and then link them to resources. And if things like transportation, to get back to your final hearing, or understanding that you can get paid for the day off through sick and safe leave, you don't have to incur that cost. Just helping them understand what's available to them is going to be the focus of the court liaison.
From those two positions, what types of initiatives, programming, opportunities can we expect from the prevention coordinator as well as the victim services cohort? Is it anything that you guys are, I know that you're a new team, but is there anything that you guys have planned out?
Yeah, so some of the things that I mentioned before, our main focuses, and right now we can talk about the high level focuses that we have, is to be able to engage community into the strategy. So doing intimate, simple conversations about what healthy relationships are, unhealthy relationships, risk factors, how to identify your risk factors, safety planning, and access to resources. So actually touching the community. Councilwoman to be out there is one of our initiatives, and do training. Secondly, that we're actually moving the needle in terms of more risk assessments being done, identifying folks who need those services. Not everybody is going to call the police. So where do we meet folks at when they're reaching out for services or reaching out for care that we need to be at? So we're really trying to design the places that have gaps, training, coordination. We're also going to be incorporated into other areas of MONSE, like our CVI initiative, and working with our Safe Streets and our violence prevention coordinators to help them understand how to identify unhealthy relationships and victims of domestic violence. So there's a lot of awareness. There's also coordination. And then in terms of, like I said, helping our agencies understand how to do more risk assessments to connect folks to resources is our primary start.
Okay, I'm going to get into IPV stat. I know that we have some slides about it, but I'm just going to throw some questions out. I'm pretty sure they're covered.
Sure.
The first is the makeup of the IPV stat data team. Can you talk to me about what that looks like?
I'm sorry, can you repeat the question?
The IPV stat data team.
The data team.
Yeah.
Okay.
Thank you, Madam Chair. John Huffman, who is seated here to my right, is MONSE's newly hired Associate Director of Policy and Research. He oversees not only team members who are responsible for the coordination of the Criminal Justice Coordinating Council, but also our data analytics team. Joseph, where's Joseph? Oh, in the back here, Joseph Mulhausen is the Deputy Director of our data analytics team.
Okay.
No data analytics team existed prior to MONSE's existence. There, for the agency, was only one data person that was responsible for reporting on Safe Streets data only. Joseph oversees a team of 3 individuals, 2 of whom are data analysts that work closely with our team around making sure that we are able to create things like GVRS stat, IPV stat, make sure that we're digging deeper in the creation of our Apricot case management system, again, a system that didn't exist before the creation of MONSE. And that third position is a newly grant-funded position for warrants analyst position that will work closely with the Baltimore Police Department and the Baltimore Sheriff's Department in order to make sure that we are addressing Baltimore City's close to 45,000 open warrants.
Let's talk about the data that's being collected. Benchmarks that were introduced to analyze any stat changes, any success rate of programs in place.
I'm sorry, can you repeat your question?
Yep. Let's get into what the type of data that's being collected. I'm not sure if you guys have the slide on that information.
Yes, we do. So for IPV-STAT, and like I said, it's the first version of this, we wanted to just scan the agencies and determine what data is currently being collected that relates to domestic violence is the term that we use more broadly, but then really drill down to see if we can get to intimate partner violence. And so you will see we're looking at all of the crime data. We're looking at all of the crime data to make sure that we understand the trends that are happening. So we're looking at total domestic violence crime. We're looking at homicides. We're also looking at rapes, robberies, all of the different types of crimes that are available to us, property damage crimes as well. And then we're also looking at data that's coming from our House of Ruth in partnership with the Baltimore Police Department, our lethality assessment protocol, which is when one of our officers will respond to a domestic violence incident and dispute and administer a risk assessment to determine the risk of lethality. That data is then transferred to the House of Ruth, Maryland, where they will make a call to the victim to talk to them about safety planning, access to resources, whatever they need. That data is collected by the House of Ruth. They provide that information to us. So we're looking at how many folks are actually being assessed and calls coming in, how many reports are being sent to the House of Ruth so that we make sure that we can look at that in conjunction with the number of crimes that are happening and that lab assessment is occurring at the same rate. How many people are actually connecting to the House of Ruth to follow up for services and that they're actually taking advantage of those services. So we look at that data. We're also looking at data from the Sheriff's Office to determine how we're doing with protective orders. The Baltimore Police Department, they do serve our interim orders, but the Sheriff's Office are there to serve our additional orders for protection. How are we doing with that? We look at guns seized. How many weapons are we taking off the streets? We look at things like, what else did we look at? Protective orders, yes, protective orders. On the screen, you'll see there. What we also look at is the number of protective orders that are actually being applied for, and I mentioned this earlier, but the number of final orders that are being issued, right? And see if there's a gap there, and why do we have that gap? So the slide that's on the screen talks about trends. We can see that big dip around COVID when the courts were closed, but then you can see some of the trends that we have orders being sought, but we then have a number of folks not coming, they're failing to appear, or asking for a dismissal. So we're looking at that data from the court as well. So those are some of the things.
Have you all, and again, just knowing this stuff is relatively new, a lot of the programs, some are established, some you guys are just establishing. What benchmarks, if any, what benchmarks, if any, have been introduced to analyze the stat data as well as success rate of programs that are already in place?
Yeah, we're still in the infancy stages of understanding that, Councilwoman, but those are all insights that we hope to be able to lift from this data and collecting it. This is only the second version of it, but we will definitely be looking at that. We also want to look at 911 data. The fire department is going to be able to start to drill down the IPV to determine how many 911 calls are related to IPV. That's new. That won't be coming out until the end of this year. Case dispositions, what's happening in the court. So there's a lot of data that we need to really drill down. And that's one of our main priorities as we start. Where is the data? What are the benchmarks? Where are the gaps? Where are the trends? Before we start to activate, that we activate with a data-driven approach as we develop this strategy. Where do we need to spend our time and efforts to really be able to see results?
Thank you, Deputy Director, and you have something to add?
Yes, Madam Chair. I would also add that as a part of our contracting process with each of our partners, there are key performance metrics that we have built into those contracts to hold folks accountable that are both quantitative and qualitative. So we aren't just talking about the number of folks that you have served, but talking about outcomes associated with what that service has yielded individuals. To the point that the director has made, this, quite frankly, is our first really deep entry into this space, given that the victim services team never truly had the level of staffing and or resource allocation that it needed prior to the Scott administration. And so these benchmarks have just been created, and we're well on our way. We are happy to share with you what they are from our data management system post this hearing.
If you could furnish that to the committee, we would appreciate that. I'm going to move on to, I have a question for BPD, then I'm going to open it up to the floor. I see you, Councilman. So for BPD, and like Deputy Director Lee as well as Director Jackson mentioned, a lot of these numbers have went down. And I do appreciate you guys for getting us all the information that we requested for 2020 through 2023. I do want to talk about aggravated assaults. From the information that you shared, 2020 we were at 1,727, 1,727, 2021 1,977, and then 2022 2,370 victims for aggravated assaults. Can you guys speak to the rise in aggravated assaults and what's happening here? What trends are you seeing there?
Colonel Brown. Good morning, Madam Chair. Colonel Brown for Criminal Investigations. I'm not sure that we can make them all domestic violence related, or just say that we have one system or one point of why. When we look at some of our data, what we have is from the age group of 18 to 35, even in our non-domestic violence, we have about 805 of them that are contributed to the aggravated assault, which would lead me to think that there's some other type of personal conflict, some other, incidents that is relatable to that. And then when you look at, for our domestic violence, our numbers is still high within that same category for domestic violence related. So about 765 of them that we can attribute to say that they are either domestic violence or inter-partner related.
And thank you, Colonel Brown. I guess, and give me 1 second, I'm just trying to center my thoughts.
Yes, ma'am.
I guess because we know, and just so everybody knows, we're not just here for DV or IPV. This is all cases across, this is all violence against women. I guess since we know that some may be due to personal conflicts in other matters, how are we working collaboratively, or is it something that your agencies are doing, noticing that there is a rise in aggravated assaults? How's everyone working with the police department, or what programs are there to say, hey, the homicide numbers are down for female victims, the shootings are down for female victims? I can clearly see this from the numbers that you provided, but the aggravated assaults are going up. So how are we working collaboratively to get to the bottom of this? And you see where I'm going? Thanks, Director.
I do, ma'am. I would reiterate the points that I made earlier with regard to the interagency collaboration that happens between MONSE, the Baltimore Police Department, and the Baltimore City Health Department, and recent collaborations that are happening with the Mayor's Office of Children and Family Success and Baltimore City Public Schools. This committee may be reminded of the fact that we are well on our way to implementing community violence intervention programming in 3 of Baltimore City's most violent schools. And while I don't have the numbers associated with the female population of those incidents, and can provide that information to you post-meeting, what I would say is that around the matter of conflict mediation, conflict transformation. We've heard directly from the health department with regard to the trainings that they are engaging in with students in partnership with Dr. Brooks's office. I would offer that the health department and MONSE are also in conversations as recently as this week with the chief of staff of Baltimore City Public Schools and with Dr. Brooks around a retreat that we'll be undertaking specifically meant to address violence in our schools and the causes of violence in school, much of which is rooted in social emotional development, much of which is rooted in the need to understand how to transform conflict in healthy ways. And we use the data that is provided by BPD to really drive the decisions with regard to where we should be moving next in the prevention and intervention space. And I don't know if other partners have anything to add here.
Thank you, Director Jackson. I would also like to add, just to what you're saying, that we do also have two partners that are partnering with our young students, ages 10 through 17, on prevention and intervention, to be able to meet with both our young men and young women on how to interact socially with one another, and also to address youth violence, but in a way that we're addressing it through a social-emotional approach. So I wanted to add that as well.
You guys kind of led me into this, so I'm gonna follow up on that. I know that program was a $700,000 grant from the National League of Cities for that program. When are you guys slated to start? Before it was spring, I think it was the spring semester 2022. Are you still slated to start in those 3 schools then?
It was academic year 2022-2023, which is what we're in now. And so we are, I would say that we're in implementation phase right now. We've already gone into each of the 3 schools and have partnered with those principals to identify spaces that the individuals that will be coming into the schools will be working, and that we are working closely to finalize the details associated with the community-based organization that's going to be contracting with us in order to do this work. And so again, I would say we continue to be on target for spring semester, which is right around the corner with regard to doing this work in schools in particular. I did want to come back to a point that I didn't make, that I think I would be remiss if I didn't make. I do believe that we all have room for improvement with regard to how we're addressing conflict transformation in the adult female population, and really looking to make sure that we take the time to have those conversations around what prevention and intervention methods should look like there.
So knowing that these statistics, that I'm seeing a lot of this is the 18 to 35, that's where we're getting the largest numbers. So when you speak about the adult population, if BPD does their part, what programs do we have specifically for that 18 to 35, the group that's hardest hit?
Anybody else want to go first?
But
Monty?
what does the agency collaboration look like, knowing that these are the numbers and this is the group? So how are we targeting this specific group to get a decline, a larger decline in some of these numbers, especially around aggravated assaults?
So I would remind the committee that community violence intervention, while it works with Black men and boys, also works with Black girls and women in this space. We have a significant amount of violence intervention workers and violence prevention coordinators who are women, who are a part of the Safe Streets work that the city implements. Again, as I mentioned before, do believe that there is more that we could be doing in this space, and would offer that I believe that we should be having more conversations than we are about this particular population. I would turn it over to any of my peers to specifically speak to anything that you all are doing individually as agencies in the 18 to 35-year-old age group. But to your point, Madam Chair, there is more that we could be doing.
Thank you, Madam Chair. In the Baltimore City Health Department, 18 to 35-year-olds are a incredibly important target group for women in the Bureau of Maternal and Child Health. We do home visiting services for these women who are pregnant, so pregnant people, those ages, and we also serve them through our WIC offices. And for those women who have children 0 to 5 or 0 to 3 who have special needs, we will see them through our early intervention offices. So there's a lot of touch points, they'll say, and that's why we focus on screening around IPV in particular. The home visiting services themselves, well, I don't think there's a direct intervention around conflict resolution. It's a point that I'm taking very seriously, writing it down, noting what we can be doing in our touch points to be thinking about sharing information about risks of violent behavior, what the potential consequences are. We can share educational materials for sure, just getting the awareness up around the issue. In many of our areas, we reach at least 20,000 families in the city through WIC. We're very closely partnered with the Department of Social Services. We use those waiting rooms to share a lot of information around infant safe sleep, so we should be sharing information around these subject areas as well. So I can see a major opportunity for education that wouldn't require a lot of additional funding other than the development of the material. In terms of program interventions, like I said, for women, particularly because many of these women have experienced something as young children in some sort of way, so they're already oftentimes reluctant to be sharing. It takes a lot of trust building, between 5 to 7 contacts with women by the same person before they're even beginning to share information around what is maybe going on in their household. So program interventions need to be fairly deep and comprehensive in terms of funding. But the first point, and I think one of the most important points, is educating people to also be aware of what's going on with your neighbor. If you're hearing things in a household next door, don't say, "Oh, yeah," once you know that something's happened, that you haven't mentioned something to somebody. So see something, say something. I think a campaign around that could be incredibly useful, and we have many partners in the Bureau of Maternal and Child Health who could be helpful with that 18 to 35 age range.
I think the final point that I'll make here with regard to the group violence reduction strategy is that there is a partner that we are engaged with that targets not just men but women who are potentially involved in group violence and who have engaged women that we have identified through the strategy in ways that have yielded positive results to date with regard to removing them from a life of violence and pairing them with a life coach. And life coaching is one of the critical components of the strategy in ways that help folks start to figure out emotional regulation, which is directly tied to conflict transformation.
Okay, thank you all. We're going to go to Councilman Torrance, and then we're going to go to Councilman Conway for questions. Councilman Torrance.
Thank you, Madam Chair. I'm happy about the information that we're receiving, but I still have a lot of data questions. So I'm going to hit you all with a lot of follow-ups and actual specific documents and memos I want from you. I'm going to be very specific. For the health department you choose, I want to know the number of young people that we refer to intimate partner violence, like how many referrals we're making from our actual schools, by school, and who in that school in terms of whether it's a nurse or a social worker that made that referral, or an actual teacher who's actually implementing the actual curriculum. In relationship to maternal mothers as well as our WIC programs, are the referrals coming from our practitioners? Are they being referred to CPS in terms of children that may be exposed to domestic violence, as well as are we referring the women to make reports? Are we encouraging them to make reports? I just want to know explicitly. I just want to know those numbers because I've seen, like from reviewing your presentations before, that there isn't data captured about referrals. And then in relationship to Muncie, I would like to know how are we proactively following up with repeat offenders? Because often I know that is the hardest population to narrow down, especially through the 18 through 35. So I would like to know how are we using our prevention coordinator to proactively on those final orders follow up with women, because often they don't feel safe after those orders are been put in place. And are we proactively, and from a non-law enforcement perspective, following up with them directly to alert law enforcement that there's a potential risk that may be still looming? That's my follow-ups. No questions, but just follow-ups to understand more specifically the work moving forward.
Just a clarifying question, if I could, with regard to his request, ma'am. So when you say repeat offenders, are you speaking about the person who is alleged to or convicted of committing violence against a woman, or are you talking about women who have been repeatedly victimized?
Thank you. Both, actually.
I set
actually,
myself up for that one. Thank you.
Yeah. So I want to know both, because I know two things is the pattern, right? There are persons who continually do it, and there are persons who have been victims multiple times. So how are we proactively preventing both, right? How are we giving you the CBT therapy as a person who continually does it to change that perspective on how you deal with conflict management? And then for a person who has repeatedly done it, who has been a repeated victim, how do we educate you on recognizing those signs, but also protecting yourself in a way where you are able to change a cycle of being a victim as well? And I don't mean victim in the way of being a victim, but how to prevent the same behavior from happening again.
So, Sophia, it looks like we have a few for the health department. We have a few for Monty. Matt is going to make sure that we have the information. We'll pass it on to you so we can get the information furnished to the committee that Councilman Torrance is requesting. Councilman Torrance, did you have anything else?
No, ma'am. I just want to know the nuts and bolts of how it works. That's it.
I got you. Okay. Councilman Conway.
Thank you, Madam Chair, and thank you again for bringing this back up. I think this is an area that both you and I realize that, is very important for a number of reasons. I wanted to go back to some of the initial impetus for why both Chair McCray and myself started to focus on this issue, and it goes back to a point in, I want to say 2020 or 2021, where we saw a significant increase in domestic violence, and it was very particularly tied to economic challenges at the time. Have we seen any change in behavior, crime, actions related to domestic violence in light of today's economic changes and challenges? We can start there.
So we are still obviously actively in a pandemic, right? And so situations like economic challenges are still readily an issue for folks. I can speak to the national statistics. We're still gathering data with respect to Baltimore, but the calls to the hotlines are still up. The requests for services are still up. There are still issues regarding reaching out. So there's hidden victims who are not calling. And so all of those are still in existence. I will tell you anecdotally that there is a slight decrease, but they're still higher than they were pre-pandemic.
That's good to know. I think it'd be helpful for us as we're thinking about IPV stat to always keep that in mind as we're seeing challenges economically or changes in prices, inflation and otherwise, how that may impact families. And even more specifically, it goes to my next question. When we're thinking about the resources that we offer and the services that we offer to, of course, victims, but also perpetrators, a lot of this stuff is often economically tied to whatever they may be going through, job loss, difficulty, and many other forms related to economic challenges. So I'm curious for the programs that we have, and I can't name them. You can certainly probably do that, and I'm not sure if that'd be helpful to do so now, but are we seeing any return in that investment? Do we see that folks that we're helping using those programs, that they are less likely to be involved in a violent incident or to perpetrate in that instance?
Yeah, there's tons of research that will tell us that abuse intervention program is an effective means of changing behavior. It does provide the motivation. Wraparound supportive services for folks who are causing harm are important. Separation from your partner is just one step, but how do you work on the behaviors that help you change your actions for the future? Because even if you're not with that one partner, you're going to be with another partner. And so partnerships with, like I told you, our focus with our ARPA funding was to really invest in our abuse intervention programming. There are 4 certified for Baltimore City. We've already started investing in 3. We're going to swing around and get that other 4th one and keep investing in that as part of our strategy. But also finding ways like the House of Ruth, innovative ways to remove those barriers that keep them from completing the program. Now, completion of a program doesn't guarantee change behavior, but that is a start to accepting accountability and responsibility and connecting that victim who chooses to stay with their partner and understanding how those changes are actually taking place in their home. My wish is that or my dream is that actually as we get started and build some momentum, we'll be able to do a study on that. Are there really change? Those are the outcomes that Director Jackson was talking about, really helping us understand the impact.
Thank you. I encourage you guys, when thinking, you asked a question, a broad question, how do we measure that success, and how do we measure the success of our programs? I think that'll be really telling. One, keeping a good sense of where we are over time economically and the different things that have an impact on families, on relationships. We know that the economic situation is certainly one of them. You know, keeping that in mind as we roll out different portions of this program over time, just so that when we look back, we can have a pretty good assessment on how well these things are working and where we're seeing the best returns. The last thing I want to say is more just a point that I thought was interesting. I was reading the paper, not the paper, reading Axios this morning, and they were talking about a report released by the U.S. Secret Service about mass shootings in America, and they found that there was a tie between the perpetrators of those mass shootings and misogyny and domestic violence in their past. We talked about why this topic is particularly important. It's often an early indicator of potential other problems down the line. And going back to what I was alluding to earlier, if there are ways for us to intervene, to connect those potential perpetrators or former perpetrators to resources, mental health issues, whatever the case is, to get them off of a potentially tragic path, we want to make sure we find those opportunities wherever possible.
Madam Chair, may I make a comment?
Yes.
Onto that point? This is exactly why we have child fatality review. What we're doing in child fatality review is looking at the number of ACEs, the adverse childhood experiences that are happening to children. We know that children with a high number of ACEs are likely to become either a victim or a perpetrator of violence. If we're not looking at this issue as a life course issue, where it happens from the time that a baby is conceived all the way through the time that they're adults, the number of experiences they have are going to be predictive of what's going to happen in the future, irrespective of economics, because this is a study by Kaiser for middle-class families. So it was not, the ACEs is not something that's specific to an economic situation of poverty, where that's only going to accentuate or exacerbate this particular point. So I do think a data point that we are collecting are ACEs. I think looking at ACEs population-wide and seeing if we can look at how we reduce those ACEs will have a long-term effect on this. And the other just tie-in that we failed to mention was the tie-in to pet violence or to animal violence. That's often a predictor of violence to children or to women or to men. And so the Animal Control Office obviously is another area where if there are incidents, there should be referrals made when pet abuse or animal abuse is seen, because that can often precede then more significant issues.
Madam Chair, if I can just add one point, I really appreciate that. I think there are very large attempts, programs, and efforts to attack these issues, and then I think we also sometimes have an opportunity to be very pointed in our approach. And when we identify issues of someone going through some crisis, economic, mental, physical, who knows, where is it that we pull in MONSE and our resources from that office to help that person and keep track of whether or not it actually makes a difference for that person over the long term. Because I think that'll tell us a lot more about our broader efforts and where we should be spending our time, effort, and money. Thank you, Madam Chair.
Thank you. Councilman Dorsey, Councilman Bullock. Okay, so I just have a few questions for our police department, and then we're going to hear from the House of Roof. They are joining virtually. This hearing is also for community-based organizations, and they're going to talk about, we're always talking about outcomes, results. They're going to talk about some outcomes or results from the ARPA funding that they have received. But before we get there, for the police department, at our last hearing, I asked about the strategic goals. What were the strategic goals to reduce the number of female homicides? I can clearly see from these numbers that they've come down, and it's something that I think we should speak to, because in 2020, there were 49 female victims of homicides. In 2021, it was 44. In 2022, the final number says that it was 31, so I think that that should be stated. But during the last hearing, I asked about strategic goals to reduce the number of female homicides. Your agency stated that it will be looking at departmental gaps to get ahead of incidents by looking at repeat victims and locations, along with partnering with advocacy groups and addressing the youth and juvenile population. At this time, just requesting what type of programming or what did you guys implement to get in front of this? How are you conducting follow-ups when identifying repeat victims and repeat locations where violence has occurred?
So, thank you, Madam Chair. I think that, as Director Jackson is saying, we have been in a whirlwind of partnership where we have recognized those gaps. We have our advocacy group that is also connected to our family crimes unit that has done an assessment for us as well and has identified just those same gaps that I know that we talked about last hearing, but also provided us with some solutions on the things that where we can improve, because we most certainly can improve some of our systems and processes as well. Working in partnership with MONSE, through Interpartner Violence helps us, develop those solutions for those gaps as well. Even when it comes to DVCC, as you heard Deputy Director Lee speaking about some of the things that we're trying to do, we need a stronger something that gives us more than just the volunteerism when it comes to sometimes connecting our victims and our suspects to some support, these services that we're talking about. And even in our review with, DV for the fatality review, just looking to see what were some other preemptive red flags that we could have provided some prevention or we could have intervened in a different way. With Major Bishop and her team, now what they're looking at, because we have been focused on is what is the recidivism, not just recidivism for our victims, but recidivism for our suspects, and how do we, as MONSE and all of the team has spoke about, how do we continue to build on services that's also for that individual who may be the one who is subjective to the cause of violence? How do we make sure that we are wrapping them around with services, support, and connecting to some mental health? I think, as Councilman Conway said, even some economic support. How are we making sure that he's not offending yet another victim again? So I think that all of those things are what we have been working for, meeting constantly, and also where we're recognizing those, we're implementing it down to our detectives to say, hey, listen, look a little bit deeper. We have the advocates, they're connecting us to all of our community-based organizations, they're connecting us to all of our support service organizations. How are we using them more effectively to make sure that we're not dropping the ball when we see one incident happen? Or when we're looking back through and we say, hey, wait a minute, this person was involved in multiple incidents, whether it be, again, victim or whether it be, again, suspect. So we're looking at our data a little bit more deeper and not just saying that, hey, listen, we know that we did our due diligence, we've gone through the process, we've made an arrest, it's been adjudicated, but making sure that we're looking more into being more support-centered, more services, centered, and not just only on with the arm of criminal justice, but how are we making sure that we are building and strengthening those relationships through our interagency partners and community-based organizations as well.
Okay, Colonel, you gave me a lot. I'm gonna go back to the last hearing. Also asked about how you guys are measuring the effectiveness of current strategies to mitigate the number of women and girl homicide and non-fatal shooting victims. At that time, the agency stated it was in a process of building out that system. I can see that you guys have been working hard on building out the system, but can you give me more information about the developmental process? are you building out a new, I believe it was a case management system. Are you building out a new case management system? Has it been completed? What details can you share about that?
So our case management system is still in the works. It won't be just specifically to, special investigations. It's going to be really for the whole entire organization to see how we're looking at it. I know that with our IT department and through our data-driven strategies and all of our partnerships really around the agency, we're definitely trying to build our case management that is going to allow us to look at data just as we need to. Not just saying that, hey, we can pull data and just look at these specifics. We're trying to make it very granular in some of the details that we're getting. So it's still a work in process. It's not just strictly, only for just, criminal investigations. It's really case management for us to see everything as a whole.
You guys know, like, we love timelines.
I know.
We love timelines. Do you have a timeline on what we at this hearing, we were at the other one? Do we have any type of estimate?
I'll take that as a follow-up. I'm not sure where we are in some of the IT part specific of it, because that is who is really helping us build out that case management system. We do have multiple meetings that's happening where we're pulling detectives, we're pulling, supervisors that have to use this technology, to make sure that it is usable for and user-friendly for the users, and not necessarily just saying we're building a product just for the sake of saying we're building a product.
Okay, so Colonel Shannon and Ms. Gabbard-Hewitt, if we can get a timeline, maybe it's broken down into phases, what has been done, what's going to be coming in those next phases, and if we can try to get some estimates on what it looks like. Just furnished to the committee. Committee members, before I get to the House of Roof, did you have any additional questions, or is everyone good? Okay. So we have the House of Roof who are joining us virtually, and they're going to speak on the outcomes and successes that we've seen as a result of ARPA investment. We're constantly talking about metrics and outcomes, so they're going to talk about the results and successes from ARPA investment.
Thank you, Madam Chair. I hope you can hear me okay, and to the rest of the council for bringing attention to violence against women as a public health crisis. Thank you to my partners at the Mayor's Office of Neighborhood Safety and Engagement for reaching out to me to specifically speak to the question, what success has been shown in changing perpetrator behavior. I want to thank Councilman Conway for recognizing the important relationship between perpetration of intimate partner violence and general community violence, and a special good morning to my home district representative, Councilwoman Porter. My name is Lisa Nitsch. I'm Director of Training and Education at House of Ruth Maryland, a comprehensive agency that serves families impacted by intimate partner violence. I've worked in the field of abuse intervention since the beginning of my career in 1998. I chaired the Maryland Abuse Intervention Collaborative for more than a decade. I'm a board member of the National Resource Center on Domestic Violence. I've co-authored a number of studies that are published in scientific journals, provided technical assistance to the United States Department of Justice, the Department of Health and Human Services, the National Institutes of Health, and every White House administration since the Clinton administration. I currently serve on the steering committee for the National Battering Intervention Network, and I'm an appointed member of the Governor's Family Violence Council, as well as our city's own Domestic Violence High-Risk Task Force and Domestic Violence Coordinating Council. And I appreciate your patience while I share those credentials, because I want to assure you that you have true expertise at your service within me and my team at House of Ruth Maryland. Abuse intervention strategies are the most underinvested area of intimate partner violence research and practice. That statement is not debated in our field, but despite these limitations, Baltimore City has much to be proud of. Though we're most known for our emergency shelter and other survivor-centered services, House of Ruth Maryland has been serving partners who are abusive since we opened our doors in 1977. Today, we have one of the longest-standing, well-designed, and evaluated programs, not just in the city or state, but nationally. Annually, we serve anywhere from 500 to 600 people who have been abusive toward an intimate partner. And our intervention programming model is different from and proven to be more successful than anger management programs, clinical therapy, or couples work. We have a curriculum that is trauma-informed and written in partnership with the University of Minnesota's Institute on Domestic Violence in the African American Community to be culturally relevant to our program participants, which are overrepresented by low-income Black residents. We address their own systemic victimization, their ACEs, and their ability to recover from trauma histories and make new nonviolent futures for themselves and their families. That curriculum was published publicly in 2019, and since that time, even in the midst of a pandemic, we have trained over 150 abuse intervention professionals nationally from the Bronx to San Francisco to use that curriculum in their intervention work. I want to be very clear. the individuals who are referred to our program each year through the criminal system are not representative of the whole of the abusive population in Baltimore. They represent the families who are in highly policed and overly dense and under-resourced communities, and those who depend on public intervention. In fact, a 2019 study co-authored by some of my House of Ruth Maryland colleagues and our research partners at Johns Hopkins University reported that while Black women in Baltimore City report having the most negative outcomes when there is police involvement and have the least confidence in the legal system as a source of safety for their families, they are also the most likely to depend on police intervention for their safety. Our program has been evaluated by a multidisciplinary team of researchers from UMBC, the University of Baltimore, and Johns Hopkins University that has shown to decrease not just intimate partner violence recidivism, but the perpetration of any violent crime by 40%. And we know that this is related to the programming because of the dosage effect we see. Where receiving some programming results in better outcomes than those who receive none, but not as good outcomes as those who successfully complete. The research model and findings were peer-reviewed and published in the American Psychological Association's Scientific Journal in December of 2021. Today, the same team has come together with support from the National Institute of Justice to evaluate our program expansion, which includes partnerships with the Mayor's Office of Employment Development, Shepherd Pratt, the Family Tree, and soon the Baltimore Community Mediation Center, to take a whole-person approach to our work and compassionately address the well-researched and defined 8 major criminogenic indicators. This model is based on the national best practice of principles of effective intervention, and these findings are due to be published in 2025. Historically, the program has had a sliding scale fee from $10 to $70 each week. Knowing our dependence on fees was not only a barrier to getting court referrals, but also a barrier to rapport building and participant completion. I'm so proud to report that thanks to support from the Justice Reinvestment Act funds through the Governor's Office of Crime Prevention, Youth and Victim Services, we were able to make the program free of charge to Baltimore City residents in March of 2022. Thanks to ARPA support from MONSE, it will continue to be free through at least September of 23. As predicted, we are on track to exceed our 15% increase in successful completion rate based on as a result of the elimination of those program fees. Today, every service offered by House of Ruth Maryland is free of charge, no matter who we're serving. The greatest barrier to our ability to evaluate the program is the limited access to criminal justice statistics through CJIS and DPSCS tracking systems. However, on the day-to-day, we do see some promising trends. 84% of our participants are able to identify a minimum of 5 abusive acts they have used and demonstrate empathy by identifying the potential impact those acts have had on their partners and children. 67% of our participants demonstrate an ability to what we call appropriately assign a responsibility for abuse, which is a metric that we co-created in partnership with the Weinberg Foundation and National Resource Center on Domestic Violence that we share nationally now, where we understand that victims who enter programming also often blame themselves for the violence they've experienced, and the abusive partner is all too happy to lay that responsibility at their feet. What we'd like to see through all of our program is that our victims and children being served move taking responsibility for abuse to putting responsibility of abuse on the abusive partner. And we like to see the reverse is true in our intervention programs. So 67% of the people who come into our program say they are not responsible at all for the abuse that happened in their relationship, but upon exiting, take responsibility for that violence. According to the self-report of those who successfully complete our program, 94% that report that as a result of the program, I am less likely to be violent toward my partner. 97% self-report that while in the program, I have learned things I can do to avoid abusive behavior. And a metric I'm most proud of is that 99% of our participants report that I feel I am a better person as a result of participating in the Gateway Project. Development is still currently in the works, and that includes partnering with the victim advocates at the Baltimore City State's Attorney's Office and the Division of Parole and Probation to coordinate efforts to identify and contact the partners of individuals enrolled in the Gateway Project so we can expand our current measure of success, which is criminal recidivism, to also include the gold standard of measurement in our field, which is the victim's assessment of participant behavior change and their own personal safety. Adding the Baltimore City Community Mediation Center to our partners list so that they can provide mediation services, but also skills training for our program participants to increase their confidence and their ability to remain nonviolent while managing conflict. And lastly, with support from Johns Hopkins Innovations and Community Safety Fund, we are building a mentoring program which includes professional development opportunities for program completers to mentor newly referred participants to generate positive community support for behavior change. The Gateway Project includes 6 full-time facilitators, a clinical supervisor, and 4 administrative staff. They host 21 weekly group sessions that serve people of every gender, including those within the LGBTQIA communities, in both English and Spanish. We also have a robust partner engagement program because decades of data tell us that the victims partnered with our intervention program participants are most likely to have used the police as a resource for safety and are unique from the population of survivors that reach out for traditional services through hotlines or other means. The engagement program contacts current partners, past partners, and co-parents of our participants to offer services and safety assessment and planning. I'm proud of the ways that we have built programming to best serve those who are historically referred to our program, but there are very important communities we are still missing and need resources to reach. Our program is a 28-week psychoeducational model that uses a group format in accordance with established best practice. Free or not, as you can imagine, convincing someone to voluntarily participate in such a long-term behavior change program can be quite a challenge. I want to echo Wendy Lee's position that we must reduce our over-reliance on the criminal legal system as our only response. Those who will never be engaged in the criminal legal system, either because their victims are too scared to come forward, their community does not take their violence serious enough to confront, or those we see in offender typology research use abuse techniques that employ psychological torture tactics that do not violate any criminal statute until they become lethal. Based on our experience and our most recent report from the Baltimore City Domestic Violence Fatality Review Team, this is why I continue to request support from anyone who will listen to help us establish drop-in volunteer information groups in various locations throughout the city that will be more likely to receive community-based referrals from family members, faith communities, and other social organizations. Such a group model will also provide a community-based resource for those families I mentioned before who may not want to engage with the criminal legal system. I appreciate the potential Director Jackson spoke to for those within the mayor's community violence intervention strategy to increase their knowledge around not just the dynamics of intimate partner violence, but also specific strategies for engaging the partner who is abusive, in addition to partners who have been victimized. Additionally, as Wendy stated, we are in desperate need for analysis, both dispositions from courts and case outcomes from the Department of Public Safety, which within Maryland is a state-run organization. DPSCS updated their database and ability to track this data in August of 2020, but to date, they have not yet been able to train agents to use this updated system that could provide critical case outcome trend information we need. To be clear, I don't mean to pile on to the supervising agents who serve as our community partners. They have overwhelming caseloads and as a result are simply unable to implement what we know are best practice in case supervision. The good intentions of the Justice Reinvestment Act, which has thankfully reduced the over-incarceration of Maryland residents, also unfortunately includes second-degree assault as a non-violent crime, which means that an intimate partner violence offender who violates their probation is limited to serving a maximum level of 15 days for the violation. We have had participants in our programming frustratingly say, I don't care about doing this, I'll take the 15 days. We continue to advocate to have the JRA revised to remedy this problem. We, residents and workers in Baltimore City, have much to be proud of in the work being done to engage people who abuse their intimate partners. I also believe we can do so much more. Thank you for your time.
Thank you. And that is going to, I want to thank everyone for joining us today. The committee is going to reconvene in the future to continue this important discussion. This hearing is now in recess. We're going to reset for about 5 minutes, and then we're going to go into the next hearing. Thank you. We are now going to start the hearing on Resolution 21-0071R, investigative hearing developing a coordinated response to Baltimore City's overdose crisis for the purpose of requesting relevant agencies to come before the Baltimore City Council to provide a comprehensive briefing on the city's coordinated response to the current overdose crisis, as well as the examination of the prevention, diversion, and rehabilitation programs we have in place to save lives. For this hearing, we're going to start with updates from the agencies, and then we're going to have an opportunity for committee members to ask questions. And after that, we're going to move on to public testimony. In the chambers for the committee for this bill, we do have Councilman Mark Conway, as well as Councilman Ryan Dorsey present. I want to again begin this hearing by thanking all of our city agencies and organizations present today to discuss this issue. It has been a little over a year since we last convened, and this matter is just as pressing as ever. I will start by being frank. The prevalence of substance misuse, opioid overdose, and intoxication-related deaths have become the #1 closeted and concealed nationwide epidemic. This epidemic knows no bounds, plaguing all identity groups and geographic areas, and Baltimore City has not been immune. Between 2013 and 2020, our city has seen a 318% increase in fatal overdoses. In 2021, we lost 812 neighbors, family, and friends to intoxication-related fatalities between January and September. The overwhelming presence of fentanyl in the U.S. led to a 7,500% increase in fentanyl-related deaths. And 92% of all illicit drugs in Baltimore City have fentanyl within them. And 89% of our loved ones we lost to this disease in 2020 were fentanyl-related overdoses. With that being said, the Maryland Overdose Data Dashboard has shown that fatal overdoses have decreased in Maryland over the last 12 months, despite a continued rise nationally. From September 2021 to September 2022, Baltimore City saw a 14.8% decrease in fatal overdoses from all substances. As we evaluate these changes and trends, it is imperative that we continue to convene to analyze existing data and demographic inequities, what cross-collaboration looks like between our agencies and community-based organizations, what our current initiatives are, and what benchmarks we have in place to access their success and timelines for new and innovative techniques. And despite promising trends, overdose deaths are still about 3 times the rate of homicide. I'm going to say that again. Despite promising trends, overdose deaths are still about 3 times the rate of homicide in the city. And it continues to be essential that we investigate all harm reduction techniques and take every course of action to prevent death and keep our communities whole. Thank you all for taking part in today's hearing. We're going to go right to our agency representatives, committee members. I'm asking that you hold your questions until we've heard from all of our agencies. We have to get out of here at 1 o'clock for another committee. So I'm also asking for the 2 presentations that we have, if you can hit your high points, and then we can get right into the questions. For our city administrator, do you stand by your report, and do you have anything to add as an update?
Thank you, Councilwoman McCray. I do stand by my report, but would like to provide. Thank you. I think I got to get used to this. Good morning, Chairwoman McCray and members of the committee. I do stand by my report, but would like to provide just a few opening remarks. So good morning, Chairwoman McCray and members of the committee. My name is Faith Leach. I currently serve as the Deputy Mayor of Equity, Health, and Human Services here in the city of Baltimore, and I am the mayor's nominee for Chief Administrative Officer. As you all know, and everyone I think in this room under the sound of my voice is aware, drug addiction is a chronic disease. Drug addiction is a disease. And just like diabetes, cancer, and heart disease, addiction is caused by a combination of behavioral, psychological, environmental, and biological health factors. The disease of addiction or substance use disorder not only impacts the person battling with the disease, but has collateral consequences that extend to family members, friends, co-workers, and entire communities. I know firsthand the impact of this disease, which has impacted my own mother, father, and a number of immediate family members. That is why this administration is working diligently to provide access to well-rounded treatment, access to wraparound supports like housing, transportation, and behavioral health to help individuals battling with substance use disorder enter treatment and forge a positive path to recovery. Here in Baltimore City, as the chairwoman just mentioned, we are disproportionately affected by the opioid epidemic. Too many people in our community are dying from overdose, killing almost 2 people every single day. Overdose death is more than 3 times the rate of homicides, as you mentioned, and we are now seeing the presence of fentanyl increase deaths across the U.S. and also in our city. The Scott administration is working to tackle overdose deaths head-on. Last year, the Office of the City Administrator participated in the Bloomberg-Harvard City Leadership Initiative. As a result of the administration's participation, the city received a fellow to support the health department's opioid work. The opioid fellow supported the health department in developing a comprehensive review of our opioid strategy and programs. Specifically, The settlement with Purdue Pharma, which you will hear more about from the health department, presented a unique opportunity for our Harvard fellow to identify the gaps and determine a framework for how we use those settlement funds. The addition of this fellow is just one way. It's one way that we are using data to drive our decision making, and one way that we are using data to drive our investments. And with the leadership and through the leadership of the health department, it is how we are working to build a comprehensive strategy to address overdose deaths in our city. So in conclusion, the mayor's office and the city administrator supports this resolution with a favorable position.
Thank you. We're going to go straight to our health department.
Thank you. Good morning, Chairwoman McCray and members of the committee. I'm Julia Roche, Legislative Affairs Director from the Baltimore City Health Department. Today, I am accompanied by Brittany Spencer, Director of Opioid Overdose Prevention. I also did want to let you know that Ms. Stacy Jefferson, Director of Policy and Stakeholder Engagement, is here from Behavioral Health System Baltimore. I wanted to let you know because they may be able to best answer some of your questions in the Q&A portion. And we stand by our report, and we have a presentation today to provide some updated information. And as you said, we will try to stick to the key points.
Thank you very much, and thank you, Madam Chair and honorable council members. As Julia said, I will be just giving a quick presentation here. I will go through it as quickly as I can.
Thanks,
So some of the topics that we will cover here today include just taking a look at some of our stakeholder committees, our partnerships, our funding, highlighting some of our programs, and then also looking at just a definition of what the opioid treatment centers are here. Okay, so our OIT, you may have heard of it, called the Fentanyl Task Force or the Heroin Task Force. That is the same convening. It is the Opioid Intervention Team, otherwise heard of as the OIT. It really is there to help focus and invigorate efforts to combat opioid overdose. And it's composed of a wide variety of stakeholders from government agencies, medical community, the community-based organizations, and they're charged with developing a citywide response plan that reflects the needs of Baltimore City residents. Our strategic plan, which we went underway in 2020, was intentionally aligned with the OOCC, otherwise known as the Opioid Operational Command Center at the state. Those buckets include prevention and education, environment and public safety, treatment and recovery. Again, when we went through that strategic planning process with our consultant, we really wanted to make sure that it reflected the needs of Baltimore City, and therefore we did have 3 listening sessions with people with lived experience. We opened it up for public comment, and we also had, of course, our internal OIT meetings with our strategic planner. Okay. Moving forward, the OIT has made the recommendation to establish an OIT executive committee. And that executive committee will include agency and organization leaders, as well as subject matter experts. As the city anticipates opiate settlement funding, we really felt strongly about establishing this group so that we can set forth the framework for funding needs and support a coordinated approach, and assist with the implementation of programs and policies, and really make agency level policy and program decisions, really trying to make that needle move. And so that was one of the biggest contributions that as CAO Leach has said, that we did have that Harvard fellow come and work with us for a couple months over the summer, and so that was a portion of one of the recommendations from her work with us. Another one of our stakeholder convenings is the local overdose fatality review. That is, again, a diverse group of stakeholders that's made up of a wide variety of government agencies, medical providers, and community-based organizations. We conduct case reviews to better understand the gaps and how we can improve
prevention portion. We make recommendations to address systematic gaps in services. We are underway with some of our friends and family interviewing. We are the first local overdose fatality review to conduct a family and friend interview. That is modeled after the fetal infant mortality review and really tries to take a deep dive into talking with friends and family of that decedent to find out the circumstances surrounding that death so that we really can understand and not make assumptions based on the information in front of us, which is sometimes limited. Just wanted to highlight some of our program partners, which are, again, they vary between city agencies and community-based organizations. We have great partnerships with the Baltimore City Fire Department, Department of Planning, Baltimore City School System, Mayor's Office of Homeless Services, and also recently the Department of Public Works, Mayor's Office of Neighborhood Safety and Engagement, and Rec and Park. We also work very, very closely with the Behavioral Health System Baltimore. We have a couple of projects that are under our grant funding with Young People in Recovery, Maryland Peer Advisory Council, we work closely with them, and also with IBR Reach, which is a treatment facility. And again, our funding, we are all grant funded, and that varies between state and federal funds. Some of our funding has or is going to be coming to an end. The OOCC was in the final year of the 5-year funding from the previous Hogan administration. That ended in FY22, and they did continue it for the additional year in FY23, and it's kind of up in the air what is going to happen in FY24. We are hopeful that that program will continue to go on. We also are in the final year of our Overdose Data to Action funding, also provided from the state. And our federal funding for the SAMHSA program, which was a partnership between BHSB, the health department, and the fire department, BHSB, and the health department. Some of our program highlights. Our overdose response program. So what is an overdose response program? It's essentially a program that Maryland Department of Health allows government agencies and community-based organizations to serve as a program to provide overdose education and resources to the community. BCHD became an ORP in 2016 when the program had expanded to the rest of the state after they piloted it in 2 different counties. Some of our data statistics from 2021 to 2022. You can see the numbers here. We nearly reached 4,000 people in 2020, trained and provided Narcan. 446 reversals were reported. These are anecdotal and these are self-reporting. In 2021, we reached 5,822 residents. With Narcan and education, with 1,395 reversals reported. And in 2022, 2,916 residents trained and provided Narcan and 826 reversals reported. And I know you will note that decrease from 2021 to 2022, and that truly was a reflection of a staffing shortages due to the COVID-19 pandemic. And also wanted to note that depending on the setting, most of our Narcan kits, which I do have one here if anybody wanted to take a look at what is inside of our Narcan kits, we do have, in most settings, we do provide instructions and fentanyl test strips. Again, we have a great partnership with our Baltimore City Fire Department and the Leave Behind program, which was launched in 2018. And that allows EMS clinicians to leave naloxone behind with patients and their support system. Again, statistics are, our data is here. 502 residents in 2019 were provided Narcan and education. 595 in 2020, 344 in 2021, and 303 in 2022. Our hub and spoke model of care, that is in partnership with IBR Reach. IBR Reach serves as our hub and offers same day or next day intake for residents with opiate use disorder. They provide buprenorphine induction and stabilization. They make referrals into spokes for long-term community-based community-based treatment, so that the person is able to be closer to their home, or what have you. The support and medical consultation to prescribing providers in the community is really supported by the hub and spoke model. Currently there are 8 spokes. And transfers between hub and spoke is bidirectional as needed for the patient. Our levels of care is an initiative with the hospitals. All 10 hospital systems has been ranked 3, 2, or 1, with level 1 hospitals offering the most comprehensive response. You can review all of the criteria on our website, but just to give you an idea, here are the hospital systems here in Baltimore and what they are ranked. And you'll see we have 4 that are level 1, and only 2 that are still a level 3. And then our last program that I wanted to highlight today is our Healthcare on the Spot. Healthcare on the Spot is a mobile treatment team that goes out and provides low-threshold treatment to substance use disorder patients. They provide confidential services including STI, HIV testing and treatment. They provide HIV testing and treatment, hepatitis C testing and treatment. They provide buprenorphine, wound care, and case management. During the COVID-19 pandemic, SUD treatment and case management was provided through telehealth visits. And at that time, they were managing 130 patients with OUD, and about 80% retention since March of 2020. And that was compared to previous to that was 50% at month 1 and 25% at month 3. So here are some metrics for the Healthcare on the Spot. New patients treated with buprenorphine for this past year, July, so it's based, of course, on the fiscal year, so July till December, which is our most recent metrics that we just received, was 132 new patients. For the full calendar year last year, FY22, we had 243, so I believe we are on track to go beyond the 243 from the previous year. They do provide, again, training in naloxone to their patients with 84 so far this fiscal year. And they also provide COVID-19 vaccines to their patients with 244 so far this fiscal year. And then just always want to touch on opiate treatment providers and how that is defined. It is a program or practitioners engaged in opiate treatment of individuals with opioid antagonist medications. There are currently 35 in Baltimore City. BCHD supports treatment providers by addressing training needs, ensuring access to Narcan, and coordinating through stakeholder work groups. BHSB does provide the general oversight and licensing. And that is it. Thank you very much for your time.
Thank you, Ms. Spencer. Ms. Jefferson, we're going to get BHSB's presentation pulled up next.
In the meantime, for the record, my name is Stacy Jefferson, and I'm with Behavioral Health System Baltimore. I'm the Director of Policy and Stakeholder Engagement. And thank you for having us here today to be able to share some of our updates and how we coordinate with city agencies and other systems on the overdose response for Baltimore City. And I'm gonna be brief. Behavioral Health System Baltimore is the local nonprofit organization that oversees the system of care for mental health and substance use disorder services. So this slide just shows like where we fit into the system. And just really briefly, so you can see the funding breakdown when it comes to services and the fee-for-service system. There are 78,000 people who were served by the public behavioral health system in Baltimore City in fiscal year 2021, with annual expenditures of over $580 million. And how that's broken down is there are about 35,000 people who received substance use disorder services and 65,000 people who received services for mental health. And this just shows a breakdown of the types of services and our grants and contracts that we administer. It was $43 million, 179 organizations, and 289 contracts. And as you can see, there's a variety of services that has received funding. And just as a note, for every dollar that comes in, there's about 80% that goes to the community for services. And so I'll just get right into our collaborative strategies. The health department mentioned many of these, and so just to reiterate, we do coordinate with the health department on the overdose intervention team, overdose fatality review. We also do internal meetings and quarterly forums where we work with opioid treatment providers in the city. We bring them in and meet about a variety of topics. And then also we do have internal meetings with the health department and BHSB staff on overdose prevention and response. And so just some highlights of some of the programming that we do oversee at BHSB. So overdose prevention. So we have Be More Power, which is a network of people with lived experience that goes out in the street outreach. They provide naloxone kits and education, as well as help to link community members to services, and they have a variety of outreach sites throughout the city. So in fiscal year 21, they were able to provide over 18,000 naloxone kits, as well as they were able to reverse over 2,500 overdoses in the city. And the link actually at the bottom of that slide is to a recent campaign that Be More Power has headed called Go Slow. And that is a campaign, again, to educate folks in the community on safer drug use. And so we did provide that link if people want to check it out. Next is some of our programming that provides access to opioid treatment in Baltimore City. And so currently we have 38 opioid treatment program providers in the city of Baltimore. Brittany did talk about the Hub and Spokes project, so I won't go back over what that is, but we do have updated information. That says 7, but we do recently have another spoke provider that is online. And then we also have served in fiscal year 21, 234 individuals. In addition to that, we have the Methadone Home Delivery Project. This provides methadone to persons who are homebound. They may be in a nursing facility. They aren't able to get to their home methadone treatment program. And so there are currently 186 people that have been served by that program. In addition to that, we do have the buprenorphine initiative, which helps to expand access to buprenorphine for those that are uninsured. And so there's the office-based opioid treatment. There's also what's called the PCARES reentry van. And so just to go over what some of that is, so we do have the low threshold buprenorphine access project. This really offers flexible and supported like holistic program at community sites by allowing individuals who have difficulty in engaging in like traditional outpatient substance use disorder treatment settings to be able to have access to buprenorphine. And then the PCARES van this supports a partnership between the program BHLI and then also the Baltimore Division of Pretrial Detention Services and also the Department of Public Safety and Corrections. They operate, what happens is there's a mobile van that's staffed by a clinical team with expertise in treatment of opioid use disorders. It includes physicians, nurses, as well as peers. This team conducts initiation of treatment for opioid disorder with buprenorphine, as well as they do an evaluation, and they'll refer to services for substance use, mental health, or even primary care services. And then also there is information on our patient medical engagement project. So as we know, individuals who inject opioids and other substances often require hospitalization for serious medical complications, including infections of bones and heart valves and abscess. And so this is actually a key opportunity to really be able to engage patients in effective treatment for opioid use disorder. And so we partner to be able to provide that engagement in that setting as well. And then just to mention our wellness and recovery centers throughout Baltimore City. So we do have 6 centers that provide consumer-centered peer support services. And there are many individuals that are served by these programs. And just to note our wellness and recovery centers, the types of programming and services that they offer are group sessions, such as they do Alcoholics Anonymous. They do referrals to other treatment settings as needed, parenting and GED classes, acupuncture. They really provide a variety of both traditional and non-traditional services. And then also, an important part of the work that we do in this area as well includes advocacy. And so BHSB continues to advocate for harm reduction strategies. And it includes the decriminalization of drug paraphernalia and also the establishment of overdose prevention sites. And so we do participate in the Bridges Coalition, which is the coalition in Baltimore City that advocates for overdose prevention sites. And so I just included some information on a recent campaign that the Bridges Coalition launched called Yes on My Block, again, to promote the overdose prevention sites in our communities in Baltimore City. And I know that there's representatives from Baltimore Harm Reduction Coalition who probably speak to this more. And so the last thing I'll leave you all with is just some community resources that are available for people in our community. And so call 988. So if people are looking for services, SUD services or mental health services, they can call 988 to get connected. Our Crisis Stabilization Center, which they do also provide walk-in recovery support services 24/7 and no insurance is required. Also just listed some other services for families as well. And so NAMI Metro Baltimore, as well as the Maryland Coalition of Families. And so that's all I have today, and if anyone has any additional questions.
Okay, thank you, Ms. Jefferson. We're going to get to our agencies. For the police department, do you stand by your report? Okay, and for the fire department, do you stand by your agency's report?
Good afternoon, Madam Chair, members of the City Council. For the record, James Matz, Deputy Chief EMS. We do stand by our record and stand by to answer any questions you may have.
Thank you, sir. The Mayor's Office in Performance and Innovation, do you stand by your report?
We do. Dan Heimowitz, I'm the Director of the Mayor's Office of Performance and Innovation. We stand by our report.
Okay, thank you. Mayor's Office of Neighborhood Safety and Engagement, Director, do you guys stand by your report?
Yes, ma'am, we stand by our report.
Mayor's Office of Emergency Management.
Good morning, Madam Chair. Elise Gillespie, Deputy Director of OEM. We stand by our bill report.
Thank you. Department of Finance.
Good afternoon, everyone. Yes, we stand by our report.
And our City Solicitor's Office.
Elena DePietro, Baltimore City Law Department. We stand by our report as well.
Okay. Thanks a lot. I'm going to open the floor up to committee members for questions. And I am going to start. As stated within my introduction, the Maryland Overdose Data Dashboard has shown that fatal overdoses have decreased in Maryland over the last 12 months despite a continued rise nationally. From September 21 to September 22, Baltimore City saw a 14.8 decrease in fatal overdoses from all substances. I'm looking to see, do we have any statistics or information that can point to the cause of this trend?
Yes, thank you, Madam Chair. So I wanted to start by saying that we do look at that data with caution, as we are aware that there are delays in the reporting from the OCME, especially as they have been stretched due to the COVID-19 pandemic and the increase in the opioid epidemic during that time period. So I just, again, I do know that the Q3 data has shown that, but there has not been an annual report put out for the 2021 year.
Okay, so do we have for what Maryland's data dashboard is reporting from September 2021 to September 2022? I get to look at the numbers with cautiously. Mm-hmm. But is there any reason for the trends that we were seeing for the numbers that were reported so far?
So I would have to get back with you and look at the dashboard that you're referencing, but I do know that that there is some data lag, and so we're not sure that there is going to be a significant decrease, if at all.
Okay, so I'll put it as a furnished to the committee request.
Yeah.
For you guys, and just so you have it, I'm looking at the Maryland Overdose Data Dashboard.
Okay.
So that's going to take me to our Office of Performance and Innovation. Just one question. At the last hearing, within the report, you guys did state, hey, we don't have a dashboard, but you are willing to work with any agencies regarding information. I know that one of the reasons we may not have a dashboard is because some of the information may be sensitive. But for the city to be the locality with the largest amount, has there been any questions or progress or cross-collaboration on possibly developing our own data dashboard around this?
Thank you, Madam Chair. You know, for the Office of Performance Innovation, we're of course operating multiple city stat processes. Currently, those processes are not routinely covering the issues discussed here in this hearing. We have looked at some of this data in something called the Emergency Medicine Partnership Forum. But again, that's a slightly wider look at the emergency medical system. But currently, that is not something that we are working on in our stats or a dashboard that we have developed.
Okay. So there have been a number of articles. I'm going to reference the BBC article recently. It noted that U.S. teens are the fastest growing group to die from, say, fentanyl overdoses. Other states and localities across the country, they are deploying efforts to educate young populations on drug use and overdose prevention. Within USTAT, are there any key metrics regarding overdoses, regarding usage of drugs by our youth? Do we have anything that ties into this within our USTAT?
Currently, the work that we're focused on in terms of our youth data support is in support of the Squeegee Collaborative and that plan. And so, no, currently that's not something that we're looking at.
So I can add some additional color there. So while we don't look at that information as a part of USTAT, so we focus, the initial USTAT was focused on chronic absenteeism, young people that are involved in the justice system, and now we're leveraging OPI support along with Baltimore Core around the Squeegee Collaborative. But where we do get to look at this information is through child fatality review and overdose fatality review. And so we are looking at a case-by-case we are looking on a case-by-case basis of those individuals who lost their lives to overdose, or any of our young people that lost their lives that may have had substance use disorder, that we were able to identify that information as a part of the information that we review in our child fatality reviews. So that is where this information would come up.
Okay. So first I want to go on the record to say that I fully support overdose prevention sites. I fully support them. And recently, alongside some colleagues, maybe a few weeks ago, visited On Point's locations. There are 2 locations, and understand that they prevented within those locations nearly 700 overdoses, and no one died there. I saw the support from the community, how those locations have actually, you didn't know they were there. They provided an immense level of wraparound services, of mental health services within these locations. They had peer-led locations. They had other locations led by medical practitioners. So I'm looking to know, does the administration have where's the administration at on overdose prevention sites?
Yes, thank you for that question. Mayor Scott actually personally also went on the overdose prevention site visit because this is a top priority for him, and it's something that he has tasked the health department, the city administrator's office to look at in partnership, of course, with advocates and other community leaders. So this administration does support overdose prevention sites as a strategy. I want to be very clear that our approach is very thoughtful and measured when it comes to establishing overdose prevention sites. So we know that there is a lot of work that goes into standing up an overdose prevention site. So we want to ensure that we have, of course, the community engagement that would be required. We want to ensure that we have identified the right community-based partners who would run the facility, that we've identified the proper funding to be able to sustain the facility, as well as the wraparound services and supports that the individuals who may be using that site will need. And so it will be a process, and a part of that process is bringing together all of the partners needed to be able to stand this up for the city of Baltimore.
So and I know everybody here gets it, and this is why they've had no deaths there. And we're saying, hey, we're at a number where we're losing folks 3 times the rate of our homicide rate. So I guess I want to know now, we talked about a strategy. Is that a part of this strategy, putting together some team? You said you're going to put some folks together, but is that a part of the health department's overall strategy that they're rolling out? Is there something in there about overdose prevention sites?
Yeah, so it's not on our strategic plan that was created from 2021, launched in 2020 to 2021, it was launched. However, overdose prevention sites are supported by the health commissioner, and we do continue to explore what that will look like in Baltimore City. As we learn more about New York City's On Point, we are in the process of getting a trip put together for our health commissioner and some other senior leadership folks from the health department to go there. I would be remiss if I didn't say that there has been, 7 years, Rajani? 7 years worth of work that's been done by the Bridges Coalition in terms of community engagement on this topic. So, I mean, I believe that as we look at our strategic plan and re-envision what the response looks like, I think that we have to look at OPS now that there is one open in the United States. We also have to remember that these are currently still federally illegal. So, we have to look at our partners at New York City to see how they went about doing this and do it in a very strategic way for the city of Baltimore.
And guys, I want you to know I'm harping on this because there's a level of urgency that I want to see. I know that OPS sites are just one. It's just one area to help, but I think that it will help immensely. I want to see this something within a strategic plan that the health department, who has led on so many issues, the oldest health department in this country, that has led on so many issues. I want to see something in there about it. My next question is going to be for BPD. At our last hearing, you did uplift the BPD's heroin coordinator, who was geared towards tracking and overseeing overdoses. And we know that the Baltimore City Fire Department provides leave behind, say, naloxone kits and offers outreach through people, encouraging people with their SAMHSA grant. Does BPD currently distribute naloxone kits? And how has the heroin coordinator worked with the Baltimore City Fire Department to booster, say, aftercare outreach to victims of non-fatal overdoses and possibly their families?
Good afternoon, Colonel Jones. So, yes, BPD is an active participant in handing out Narcan and naloxone. This is distributed through our academy to the new recruits, as well as members who are active in the in-service training. As of this year, 2022, there were 2,099 officers who had been trained in the use of naloxone. And the numbers of reversals that were administered in 2022 was 167. There is a 1-hour class on this that is given by our education and training, and we are an active partner in this in reference to training all of our members. Up into the executive command staff, I can say myself and probably Colonel Brown have actually participated in that class. It is encapsulated in our CPR and defense tactics, where we go over CPR, they go over naloxone administration, and they provide the kits at the end of the class.
So I'm gonna get back to the second question about the heroin coordinator. How are they working with, say, our fire department to bolster aftercare? Like, what does that data look like? Say, if the fire department is dispatched to a certain area, they're providing certain details that they received. How are you guys working together, and what is the role of the heroin coordinator within that effort?
Yep, I will have to follow up with that. That heroin coordinator is out of our education and training division. I do not have those numbers. I will say that for calendar year 2022, there were over 5,000 calls for service in reference to overdose. To what the coordinator does with the fire department, I am unaware of that as of this point.
Can you furnish that role, or where's our, I'm looking for our fire. Okay, so you're hiding behind Spencer. What does the outreach look like between, how are you and BPD sharing data when you guys are reporting out, or when your EMS team is reporting out to, say, overdoses?
So with regard to any overdose that we go on with outreach to the public in general, we'll leave up to 3 of the leave behind kits that we've talked about before. And just take one step back to about 2 budget hearings ago, we're required to report our leave behind numbers by zip code. We also do number of reversals by zip code, just to kind of, and what we did is went retroactive for a couple of years. So that's actually in the Open Baltimore site. We actively share with our partners. We actively, within the last year, we're also Ray, what's that title? Opioid Response Program? We're actually a recognized ORP, which, what does that mean? That means that we don't have to go to the health department or the physicians to get Narcan. So we actually went a step further to be able to get our own Narcan to make it a little more seamless. Because Narcan's expensive, I'll be honest with you. The annual cost of naloxone for the fire department is just under $1 million a year. It runs about $37 a dose. The intranasal is a little bit more than that, but we've had quite a bit of success with that. The other thing that we're seeing with the Leave Behind program, I would go a step further for BHSB. I've actually heard the word saturated with a lot of the people in the field right now. When we actually go on scene for overdoses, we're actually seeing people getting a lot of intranasal Narcan or naloxone prior to our arrival. To the extent you can give too much Narcan, so we're kind of seeing the other side of that. But it's a lot easier to treat someone that's received Narcan or naloxone than it is as somebody that hasn't. So I think all in all, I think that part's starting to go positively. I was kind of scribbling notes when everybody was talking. The problem with a lot of these topics, and opioid overdoses are just one of them. If you listen to a lot of the history, like the OOCC, you're at the final year of a 4-year grant. You know, if you look at this, you're at the final year. A lot of these opioid programs are at the final year of their funding. And I'm starting to notice, I have the unfortunate luxury of legacy. A lot of when it goes out of sight, out of mind, a lot of this funding starts to go away, and I'm starting to see some of that slip. You know, in the beginning, about in 2018, we saw a lot of funding come through the state to be able to offset some of these huge expenses and some of these outreach programs. It seems like it's getting out of sight, out of mind a little bit. I just think maybe it's going to get renewed again, hopefully. We do work, and just to take a step back, Madam Chair, we do work closely with our police partners to see where we can and assist with leaving that Narcan behind. It gets to be how much do we have, too, I think is part of the problem, too.
Just to clarify, I think what I'm getting at is, say if we know we're here in that realm of prevention of death, right? So if we know that there are zones, and I'm sure that you guys can identify where these drugs are being sold or where these overdoses are being sold, if information is relayed, say, to the EMS responders, or you know that there is a hotspot area, I guess I'm looking to see what does that collaboration look like for you guys to get information to say, this is happening here. So likely someone is selling here.
So thank you for that question, ma'am. I would say, being a commander in the Southern District, I use my team just as you're saying. And I know that, you know, with Colonel Jones, we've talked about that even when I had our community and youth division. It is imperative for that collaboration. So what would happen is if my NCOs were out, you know, our neighborhood coordination officers were out conducting some outreach with, say, the health department, because during that time, of course, with needle exchange, if the bus is there, and most certainly with the fire department, if we started to hear, hey, we're having a spike, we had this many overdoses, not necessarily fatalities, but just, hey, we're seeing some overdoses, I can real-time deploy out that team to be able to go and do just that, whether we get the ground stash, whether we find out where the drugs were, did we make, you know, extractions by making arrests of those individuals that we know that sell in the area. It was impactful, meaning that we could slow down the pace of that spike. So that was huge for us. I'm not sure how we're collaborating, you know, down to the districts, but that was something that I employed with our NCOs to make sure that we were having those relationships and those connections, because that is really important. For us, definitely for deployments as well.
And Colonel Jones, did you have anything to add to what Colonel Brown said? Do you get this direction I was going in? I think I just wasn't clear.
No, I think what she said is correct. I would just double down on the fact that, yes, it's indicative of the district commanders to identify those spikes when they see it. That is also covered by us in our Thursday comm stats when we understand that there is obviously something going on in reference to the numbers. I would say, looking forward, we could do a better job in working with the fire department when we see those spikes. I do not know what the heroin coordinator does in reference to, like I said, I believe he's housed under our education and training. I've already reached out to the commander over there because there may be something in place that I'm just not aware of. So I just want to get the information on that to provide it at a later date. But as Colonel Brown said, yes, there's the optics of utilizing the data to see where's something going on, what's going on, who's supplying this, how are they supplying it, working with our federal partners and our interdiction teams in reference to something is going on here that needs to be addressed. So it is that granular for us, but we got to make sure that we're also looking at a co-productive response on how to address these issues.
Thank you. Councilman Torrance?
Thank you, Madam Chair. This is just a follow-up for a future hearing. I would like to have the Department of Housing and Community Development and DPW present too. When we've had spikes in my district, we've noticed that the spikes were related to persons squatting in homes as well. So just to be more holistic and understand how this helps with our vacant housing strategy as well.
Heard. Ms. Gebrin, he went. Can we just make sure that someone from those agencies are present? Knowing that this is a cross collaboration, we need all hands on deck for this one. Our councilman to my left, did you guys have any questions? Councilman Dorsey.
I don't really have any questions because you covered the main one for me, which is basically what are our steps, what's our pathway to opening overdose prevention centers? I mean, that's, to me, the most critical thing that we need to be pursuing at this point. And so if we don't have a pathway, I guess, at this point that's clearly established or that's directly kind of laid out by the health department, you know, the next step here is I want to see what that looks like. Thank you.
I had a couple of really quick questions. One day in my district, I was coming from one thing going to another and happened to come across someone who was ODing or who had OD'd. I knew that I had in my district office some Narcan, so I immediately went back to my district office and found it. By the time I got there, and an ambulance had made it there on time. It got me to thinking about a couple things. That Narcan was left over from my predecessor, so thankfully it was there, and if I was able to help, I would have. Also, that Narcan actually was expired, and it made me think about where I could get more. So I guess that's my first question. Where can we get Narcan if we were looking to get some?
Yeah, I'm happy to answer that. So there, as we've mentioned here today, there are many organizations, community-based organizations and city agencies that are registered as overdose response programs. Some of them are registered as overdose response programs for the prime reason that they want to provide Narcan to their staff. But then there are some, like the health department, that do provide it they distribute it out to the community members, like the fire department, and a lot of community-based organizations. So to answer your question, they can absolutely call the health department and we can provide them with kits. We do host 2 trainings a month. We share it on our social medias. We host one in the afternoon, one in the evenings, and then we make sure that the individual does get a Narcan kit afterwards. But there certainly isn't a shortage of Narcan. We can get it in the hands of anybody that wants it.
I appreciate that. Thank you. I will follow up with that because after having that experience, I want to make sure I have some in the office at all times, just in case. The other thought was, speaking to the training, do we have a sense for how many city employees are trained to use Narcan?
Yes, so we recently set out an initiative to train city employees. It's a huge undertaking. I have a very small team. There's 4 of us. So I can get you those numbers as a follow-up. We have a tracker that separates out city staff from regular city residents so that we can really be strategic with how we are rolling this out and going with the agencies that have public-facing staff. And so, so far we've done a lot of internal programs. We've exhausted all of the internal programs, and now we have reached out and we have talked with DPW and we've talked with Rec and Parks. And actually we've trained a lot of Rec and Parks, and the staff there have been trained to be trainers, so that that's part of our initiative, is to take some of the capacity away from us and build capacity within these other city agencies so that they can provide the training themselves.
That is great, because you kind of preempted my next question as a follow-up to that, which was, do we make sure at all that Narcan is available in city buildings? So for instance, if there was an OD right out in front of City Hall, would somebody be able to go outside right now and save that person's life?
So I would have to follow up with you on that. I do know that we have it at the front desk at the health department. We have tried engaging with security. There are some concerns, liability concerns with the agency that does provide the security staff. So I would have to get back with you to know exactly how many front desks have Narcan available. But like I said, we are actively rolling out our initiative to train as many city staff as we can.
Yeah, I think my thought here, I'm always thinking sort of chronologically, and I think we have an opportunity, at least with our city buildings, especially those that have security or front desk attendants or people who are, if someone did come through the door saying, hey, look, there's something wrong with the person outside, that person would know those symptoms and know what to do. So if we were able to target those folks, target those buildings, and target those agencies, I think it'd be a huge win for us. I don't know how often that happens, but having been in that situation myself, I was really worried that I wasn't going to be able to help, and I remembered that I did have some Narcan in my district office, so just a thought. Thank you, Director. You look like you.
Thank you, sir. So I was just going to add that as Mayor Scott committed in the Comprehensive Violence Prevention Plan, and as was mentioned earlier, the Baltimore City Health Department has partnered with MONSE in order to empower community members and business owners around the proper use of naloxone. In fact, our community engagement lane is getting trained next week by the Baltimore City Health Department, and then we'll be rolling out a training to City Hall employees in February and into April, and then spreading across other agencies and into community-based organizations and residential spaces that are interested in being trained in its usage.
Thank you. Thank you, Madam Chair.
Thank you. I applaud the health department's efforts and MONSE's efforts in making sure that we are getting as many people trained as possible. Also second what the councilman has said, all of our buildings should be equipped with Narcan. And I hope that you can, you guys have the time to get as many folks trained, especially who are front-facing, as possible.
And Madam Chair, if I could address the question that you last asked, I just wanted to circle back on that. Shannon Conway, Legislative Coordinator for BPD. In the past, the DEA has provided us with reports that we've provided to the Health Department about non-fatal overdose victims, areas where that has spiked. We do acknowledge that there have been issues with data sharing and communication, and barriers still exist, and that is something that we need to work on with our partner agencies. We have started to brainstorm ideas of how we could potentially fix those barriers. So just wanted to circle back to that.
Thank you for adding that note. I have one question, Ms. Jefferson. This is actually going to be for you if you could come. And then I want to give an opportunity before we get out of here, about 4 to 5 minutes for our folks from Baltimore Harm Reduction, if you guys want to provide any types of updates at this time. Ms. Jefferson, my question is going to be regarding 988. So we know that 988, the new number for the Suicide and Crisis Lifeline, launched in July of this year. It is funded, the new regional 988 helpline is funded by the GBRICS Partnership. And in October 2022, the HEC Committee did hold a hearing to discuss the comprehensive rollout of the helpline, the purpose, the greater impact, along with the current success and challenges. At this time, has BHSB seen an increase in calls for substance use crises since the rollout of 988 in July?
I'll have to check to see if we have it broken down, like based on the content of the calls. I'm not sure if we have that level of data, but I can check and follow up with the committee.
Okay, and the committee will follow up with you regarding those numbers.
Okay.
I believe I saw Rajani earlier Okay, did you want to provide, we're going to close out soon. Did you want to provide just 4 to 5 minutes? You have 4 to 5 minutes just to provide an update on some of the work that Baltimore Harm Reduction Coalition is doing. And just so everybody knows, this is for our agencies, but these hearings are also for our community-based organizations who are also on the ground working in partnership. And whenever you're ready, just give your name of the org and also your name as well. Thank you.
Absolutely. Thank you so much, everyone. So my name is Rajani Goodlevaletti. I am Director of Mobilization with Baltimore Harm Reduction Coalition. Honestly, I need to take a moment. I have a lot of emotions about the fact that we're even talking about overdose prevention sites so positively in here. I want to thank Councilmember, the Chair McCray, and Councilmember Dorsey, as well as Councilmember Burnett and Mayor Scott, and the leadership from BHSB for attending the On Point NYC tour with us in December. So BHRC, just to say, is we mobilize community members for the health, dignity, and justice of people targeted by the racist drug war and anti-sex work policies. We've existed for over a decade. We are a certified overdose response program. We are a naloxone distributor. We are a syringe service program. We are a food service program because people are hungry. We provide coats. We do a lot. And we need overdose prevention sites. We have on-the-ground experience with the overdose crisis. While I am so excited to hear about this potential trend downward of the overdose epidemic, we know that Baltimore has been hit by overdoses for decades, for a long time. It is time that we have more innovative solutions. Naloxone is life-saving. Naloxone is in many hands. Naloxone, when expired, can actually be effective for up to 10 years. And actually, Councilmember Conway, I am a constituent of your district, and I would happy to walk down the street to bring some naloxone over to you anytime. Get you my number. Pretty sure I gave it to Bill Henry before. So we know that naloxone works. We actually do not believe it is possible to have too much naloxone. It is always important. And people can only use it if they have other people around. Right? You can't administer naloxone to yourself. And because of over-policing, because of our stigma against drug users, a lot of folks die from overdose because they are using alone. They need welcoming spaces, particularly community-based organizations, to operate overdose prevention sites. There is only one issue at the federal level. There is the Crack House statute from 1986. And in that statute, which, as we know, something called a crack house statute is outdated and racist, right? So that is the only piece that is keeping overdose prevention sites from operating legally. New York City has a loophole at the jurisdictional level, but not the state level. In Maryland, we have been pushing for a bill at the state level for 7 years. The Bridges Coalition for Overdose Prevention Sites is a coalition that we steward. It is over 30 organizations, hundreds of people who support overdose prevention sites that are community-run, peer-run, operating in Baltimore and across Maryland. We had an event last night which 300 people registered for, The Charles, a documentary of an overdose prevention site operating in Vancouver. So many people in our city want this. There is no reason to wait. And so we are excited as experts in overdose prevention sites, how to operate them, how to implement them, how to make sure that people will use them. We are happy to lead the effort to help the city to operate these well so that they are used. I'm also happy to answer any questions at any point. Thank you so much.
Thank you. Before we close out, did anyone have any questions for Rajani of Baltimore Harm Reduction? Councilman Torrance.
I just want to thank you for your advocacy and then also your partnership with my office and also our partners in Hamden and also in Penn North. You guys have been essential when we've had spikes, and I just want to thank you for that work as well.
Oh, thank you so much, Councilmember.
So I second that. Rajani, we don't have any questions for you.
Okay, thank you.
And for all of our agencies, our community-based organizations, I want to thank all of you for joining us today, for being proactive and providing us with a lot of the data before the hearing, so we can just promote productivity. The committee is going to reconvene in the future to continue this important discussion. Before we go in recess, I do want to highlight these bracelets from my babies at Vanguard. I want you to know that I am wearing them today. I'm going to continue wearing them, and I do thank you for them. And right now, this hearing is now in recess.